يعطيكم العافية. بسم الله الرحمن الرحيم. Today we're going to talk about management of post-operative complications. Now we'll talk about post-operative patient management, soft tissue injuries, problems with the tooth being extracted, injuries to adjacent teeth, injuries to osseous structures, bleeding, delayed healing, and infection. And then references. So now, when we do a procedure, a surgical extraction or any extraction, we need to give the patient instructions. These instructions should be given written and verbal. We should tell the patient these instructions and then we should write them, give them to the patient written. Now, the postoperative instructions should explain what the patient is likely to experience, the pain, the swelling, the trismus, all of those. We should tell the patient what's going to happen, why they happen, and how to manage it. So, for example, we'll tell the patient there will be pain because of the procedure itself, because of the local anesthesia when it wears off. After the local anesthesia wears off, we can take pain medications, analgesics for that. There can be infection, we should go for antibiotics. There will be swelling, we should go for any cold packs or hot packs. We tell all the things that can happen and why they happen to the patient, and we should explain it to them. Now, the instructions that we should always say: bite firmly on a moistened gauze for at least 30 minutes. Now, we always try to increase the duration, meaning patients will not comply to us 100%. Most of them will, but good percentage of patients will not comply. So I would tell the patient bite on the gauze for 30 minutes. He might bite on it for 15, 20 minutes stops. So I would say bite on it for 40 minutes, 45 minutes, 1 hour. So once he removes it, when he doesn't comply to the instructions, we will find that we got what we wanted from the patient. We want him to bite on it for 30 minutes. He bites on it for 30 minutes. No eating or drinking for 2 or 3 hours post-op. Any bleeding up to 24 hours is normal as long as it's decreasing. Now, some patients put tea bags because it has some analgesics and some relieving factors for the swelling. They can put it inside the socket, but we don't prefer to use it anymore. Patients who smoke should stop smoking for 12 hours, but we say 1 day. Should not spit during the first 12 hours after surgery, and cool and soft foods for the rest of the day of extraction. These are the instructions that we should tell the patient after extraction. If there is pain, we take pain analgesics and so on. Now, when do we tell the patient to come back to the office, to come back to the surgery? When we have prolonged oozing, bleeding that stays more than 24 hours or increasing, bright or red bleeding, or large clots in the mouth. These are indications for the patient to come back to the surgery. Now, the most common postoperative complications: pain and discomfort, swelling, infection, trismus, ecchymosis, dry sockets. Now, bleeding, we always ask the patient to bite firmly on the gauze, like in the picture. We ask them to bite on it for 30 minutes so the clot can stay inside and not come out or have dry sockets. Now, patients will have some pain after the procedure. Now, this pain is usually characterized by increasing in experience up to 12 hours. At the 12 hours, we will have the peak pain experience. Then it diminishes rapidly after that. Now, the pain, usually not severe, can be managed with mild over-the-counter analgesics. Now, if it stays for more, it rarely stays for more than 2 days after surgery, but if it stays for more than 2 days, we will suspect dry socket or infections. Now, we can take medications as ibuprofen, acetaminophen, codeine, hydrocodone, oxycodone, all of those. Now, the first dose of the analgesic medication should be taken before the effects of local anesthesia subside. So, once the local anesthesia goes away, the analgesic starts to work, the sharp pain will not be present after that. Now, we try to stay away from the surgical site so we don't rush at the site of surgery. We don't rinse the mouth, we don't spit. We do dilute salt water the next day, rinsing the mouth. So on the same day of extraction, we do not brush the site of the surgery. Now, edema, before that, sorry. Why do we prefer not to brush on the site of the surgery? Because it will cause bleeding, it will cause injury, it can remove the clot from its place. Now, edema, routine extractions will not result in edema. After surgical extraction, it can happen. The peak at 36 to 48 hours, and it begins to subside on the third or fourth day after extraction. Now, increased swelling after the third day may be an indication of infection rather than renewed post-surgical edema. Now, we talked about the ice packs and the warm packs in the impacted tooth lecture. Now, how to recognize if there is an infection? Increasing pain, increasing swelling after 4 days, foul taste in the mouth, skin redness, and fever. All of those are indications of infection. Now, trismus usually due to the local anesthesia, and usually the medial pterygoid is the most commonly involved muscle. Ecchymosis can be bleeding in the subcutaneous or submucosal tissue. In older patients, usually 2 to 4 days, and resolves within 7 to 10 days. Now, let's talk about prevention of the complications. Soft tissue injuries, sometimes we can have a tear in the mucosal flap. While we're doing extraction, the elevator slipped and injured the tissue, made a tear. Now, it's the most common to happen, usually inadequate sized flaps or force retraction. Now, a long flap will heal the same as a small flap. So, we lengthen the flap, we do releasing incisions if needed, and we make good amounts of flap. So, when we retract it, we use good controllable retraction forces that we can prevent soft tissue tears from happening. Now, we mainly try to clean it, irrigate it with normal saline, and do suturing for the wound. Now, sometimes we can have a puncture wound by the elevator slippage, puncturing or tearing adjacent tissue. Here we try to always have good control over the instrument. We try to make it clean, prevent infections. If it needs suturing, we do suturing. Now, the most common complications after that is infections and bleeding. Now, abrasion can happen sometimes from the bear, from the soft metal retractor. We try to always put gauze underneath the retractor, for example, to prevent the direct contact or the friction that's going to happen. Now, we keep it clean. We try to give medications that will help in healing. Now, if it's small, it can heal within 2 weeks. If it's large, it can heal within a month or so. And sometimes it can cause scarring. Now, here we can see the tear. Here we can see the puncture wound, and here we can see the abrasion. Now, sometimes we can have root fractures. While we're doing extraction, there happens root fractures. Now, endotreated teeth are very common to have this problem. Long, curved, thin roots, divergent, these are very common to have this problem. Now, that's why we always need to take an x-ray. Now, once you see the x-ray, we see that the tooth is kind of difficult. We go for surgical extraction. from the beginning. Do not use strong apical force on the broken root because it can be slipped upward into the sinus or anywhere else into a vital structure. Now, sometimes you can have root displacement. Now, the most common is the maxillary molar root into the sinus. The upper eight usually goes into the infratemporal fossa or the infratemporal space. The mandibular third molars or molars, they go into the submandibular space. Now, the cause can be due to the tooth itself being into the sinus. Like the upper six, the tooth itself is inside the sinus. For the mandibular molars, for example, it can be due to African Americans, or they have very strong roots that they need a lot of force so they can be pushed by force. We can have long roots, divergent roots, bulbous roots. All of those can be causes for displacement. So that's why we need to be always careful and take x-rays. Once we take an x-ray, we try to go for surgical extraction from the beginning. Now, how to manage it? If the root goes into the sinus, this is called oroantral communication. Now, like in this picture. Now, how to assess if we had an oroantral communication? First, an x-ray, we will see that the root is not present. We can do irrigation and ask the patient with normal saline and ask the patient if he feels anything going to the nose. We avoid the Valsalva maneuver because if it's a small opening, it can become larger. So we try to avoid it. And we avoid probing as well because if it's small, it can get larger. So we took an x-ray and we found this shape. Now, first, we do single attempt of visualization. We put the suction into the socket and try to push the root downward. If it fails, we go for Caldwell lock surgery at the canine fossa and we remove the root. Now, after that, we will have an oroantral communication, a communication between the oral cavity and the nasal cavity. Now, we can go, if it's small, between 2 to 6 millimeters, we go for flaps. We go for collagen inside the socket and suturing, figure of 8 suturing, horizontal matrix, all of those. If it's over 6 millimeters, we need to go for flaps. The buccal advancement flap or palatal rotational flap and all that. And we give the patient sinus instructions: avoid blowing the nose, avoid sneezing violently, avoid sucking straws, and avoid smoking. Now, lingual plate fracture. It's very common to happen. Now, ankylosis, African origin, more mature patients, bulbous roots, all of those are risk factors. And usually it's with third molars. Now, the main risk here is the lingual nerve. It's positioned above the lingual alveolar crest at the retromolar area in 14% of the cases. So the rest, it's either at the plate or below the plate. So once there's a fracture, there is a high risk of injury for the nerve. So that's what we do. We keep it as it is. We gentle reduction, put it backwards in its place gently, and soft tissue closure with no manipulation of the area. If the root disappears during root removal in the lower molars, it might be into the submandibular space. Usually a single effort to remove it. If we can't remove it, we leave it in its place 6 weeks post-op. We do a CT scan to know its location, and then we go an extraoral approach to remove it. Now, in this single effort to remove the root, we try to push it backward into the lingual aspect, into the socket. So we put our finger into the lingual aspect of the floor of the mouth and pressure it to push it backward into the socket. And we will develop a lingual flap without releasing incisions, of course, and we try to identify the roots. If we can't, then CT we close, and 6 weeks later we do CT scan and then we remove it. Now sometimes the tooth can be lost into the pharynx. We ask the patient to put his face towards the floor and try to spit. Now it can go aspiration into the lungs or swallowed. Now if it's swallowed, that's good, it's gonna go out with the stool. If it's respiratory, it's dangerous and it's an emergency. So what do we do? If there are no respiratory distress, no coughing, then it's most likely most likely swallowed. If there is distress, if there is coughing, if there is shortness of breath, this is an emergency. We call the ER and the patient should go into the ER. And they can remove the tooth by bronchoscopy or whatever it is. Now, mostly the tooth will go into the right lung because it's larger in size. The main stem bronchi would be larger. Now, sometimes we can have injuries to adjacent teeth, like fractured restorations. We need to tell the patient beforehand. If we apply lots of pressure, it can cause a problem. We can do luxation of adjacent teeth because of the pressure. Now, sometimes with ortho, we can extract the wrong tooth. Now, one good option, we ask the orthodontist to mark the tooth without a bracket. So let's say we want to extract the lower four. He marked it with having no bracket on it. So that's how we know we extracted the right tooth. Now, other options, count the teeth: central, lateral, canine, upper 4, upper 5. Okay, we want to extract the 5. We count the teeth. Every time we try to extract, we count the teeth. We inform the patient beforehand that a crown or restoration might be broken, might need to be replaced. We need to tell the patient beforehand about all of those. Now, if we extracted the wrong tooth, we tell the orthodontist, and he can decide if it's good or bad. If it helps his treatment plan, that's fine. If it doesn't, we replace it backward, do a splint, and then extract the right tooth later on. Now, sometimes you can have fractures to the alveolar processes, like buccal cortical plate over the canine, the buccal over the maxillary molars, the first one specifically, and the tuberosity, and the labial bone over mandibular incisors. Now we need to use very controlled force and know it. For example, a high risk of maxillary tuberosity fracture will be with long-standing teeth, upper 8 that is alone and without anything adjacent to it, no 7, no 6, no 5. Now the tuberosity will be fractured with it 100%. Now here we can see, here we have a high risk of sinus communication. But here it's superimposed. As we can see, the white line, the line of the sinus is seen. There is no cutting in it. So we know that if we extract the 4 or the 7, we need to be careful, but we will have low risk of sinus communication or antral communication. Now the 6 here is extracted and we can see it's very close. Any wrong move can cause communication. Here, for example, the white line, we go with it and then suddenly it gets cut here and it gets cut here. So these two are inside the sinus. Now the tuberosity got fractured and it's attached to the tooth and we cannot remove it. We push the tooth back into the socket with the tuberosity, splint for 6 to 8 weeks, then do surgical extraction to remove the roots, to remove the tooth. If the tuberosity can be separated, we can extract. Now, sometimes, most of the time, we remove it with the tooth. if the patient is not going for a denture or anything like that. Sometimes you will find that the tuberosity is with the third molar and it's out of the bone, out of the soft tissue. What's to be done after that? Nothing. Now, sometimes the mental nerve can be injured, paresthesia or anesthesia of the lip and the chin, usually during the flap retraction. Now, the lingual nerve can be injured and can cause tongue paresthesia. The ID nerve with the third molars, as we all know. Now, sometimes the joint can be injured. By applying too much pressure and the patient already has a TMD, the patient might have some problems. So we can put support and bite block to reduce the discomfort, and after the procedure, moist heat, resting the jaws, soft diet, and ibuprofen every 4 hours for several days. Now for bleeding. Why does bleeding happen? Because the tissues are highly vascular and we leave an open wound. This will cause bleeding to happen. Now we can take good history. We talked about the management of the bleeding. Goes for 30 minutes, T-bag, cold application, gel foam. It's least expensive and with figure of 8 suturing. Surgical for more persistent bleeding. Collagen can be used as well. Here's a resorbable collagen plug. Here we can see Surgical. That's another form of it. Gel foam. How it looks. Now, dry socket is one of the most common, if it is the most common complication after third molars extraction and lower molars. In routine tooth extraction, 2%. Now, it's not an infection. We don't need to prescribe antibiotics for it. It's just that the clot went away from the socket. So pain starts to develop on the third or fourth day after the tooth without signs of infection and radiates to the ears, throbbing pain. Usually, very common or the most common cause for it is smoking. Patients do not comply to the instructions, so they smoke and dry socket happens. Now, the management, we irrigate and put a dressing material. Now, this dressing material, eugenol, anesthetics, carrying vehicle, and it's changed every other day for the next 3 to 6 days depending on the pain. Once the pain decreases, we should not replace it because it acts as a foreign body, further prolongs wound healing. Now, after ID block, sometimes we can have facial palsy. The main important thing is to reassure the patient and do protection for the eyes and lubricants with corticosteroids for 4 days post-operatively. Now, usually symptoms will be relieved after 2 to 4 weeks. And that's a very short lecture as a complications. I tried to put the most common ones to be present, and the references is contemporary oral maxillofacial surgery with some articles and so on. And thank you. If you have any questions, I'm always available, of course, anytime.